I'm Dr. Neil Skolnick, and Dr. John Russell and I have another great issue this month, going over some really important articles, beginning with an article from Diabetes Care on screening natriuretic peptide levels, predicting heart failure and mortality in individuals with type 1 and type 2 diabetes without known heart failure at baseline. Next, there'll be an article from Diabetes Care on the risk of acute pancreatitis and biliary events after initiation of incretin-based medications in patients with type 2 diabetes. Following that, there will be an important article from JAMA Network Open on CGM frequency and glycemic control in people with type 2 diabetes, and then a kind of bothersome and fascinating article from JAMA on AI-powered lifestyle interventions versus, you guessed it, human coaching in the Diabetes Prevention Program, a randomized clinical trial of these two powerful forces. Then, from Diabetes, Obesity, and Metabolism, a two-tier screening approach for liver fibrosis stratification in outpatients with type 2 diabetes. And finally, change in urine albumin-to-creatinine ratio and clinical outcomes in patients with CKD and type 2 diabetes from BMJ Open Diabetes Research and Care. Let's jump in.
Our first article is from Diabetes Care, and it looked at screening natriuretic peptide levels predicting heart failure and death in individuals with type 1 and type 2 diabetes without known heart failure. So this study queried adults who were over the age of 18 with type 1 or type 2 diabetes without known heart failure who had received an outpatient natriuretic peptide test between 2017 and 2023. The associations between the natriuretic peptides and incident heart failure or death were assessed using multivariable Cox proportional hazard models. So the study looked at over 116,000 eligible individuals. Roughly 3,000 had type 1 diabetes. Roughly 113,000 had type 2 diabetes. The patients were followed up to 7 years. 54% were female. The median age was 64 years of age. The mean A1C was 7.1 at baseline. Approximately 39.6% of individuals with type 1 and 42.3% of individuals with type 2 diabetes had a BNP greater than 50 or a pro-BNP greater than 125. In adjusted Cox models, increased NT pro-BNP level was significantly associated with increased risk of incident heart failure or mortality among individuals with type 1 diabetes. So if there was a pro-BNP level 125 to 130, the hazard ratio was 2.04. For the NT pro-BNP greater than 300, it had a 4.48 hazard ratio. So this is patients with type 2 diabetes, type 1 diabetes. Patients with type 2 diabetes, there was a hazard ratio of 1.85 for a level between 125 and 300, and greater than 300, a hazard ratio of 3.58. Neil?
John, this is an important article. Remember, you and I went over the recommendations that came out about a year and a half ago and were codified in the standards of care this past January, that everyone with diabetes should be screened with a basic natriuretic peptide annually. Well, this is a huge cohort of individuals, both with type 1 and type 2, really supporting that recommendation and showing that in both people with type 1 and type 2 diabetes, heart failure and high risk for heart failure is very common. Now, previous data has shown us that about 22% of people with type 2 have heart failure. This data suggests that it might even be higher, or these people have what's now called pre-heart failure. Why is that important? Well, we now have three classes of medicines: the SGLT2s, the GLP-1s, and the non-steroidal MRAs, finerenone, that have efficacy in preventing heart failure hospitalization. And there was an interesting article 3 years ago in diabetes care, looking at a large cohort, over 1.5 million people in an observational trial of SGLT2s and GLP-1s, showing that they decreased the incidence of first appearance of heart failure by between 10 and 30%, depending on the medicine. In addition, I'll tell you, I would bet you a lot of these people with high BNPs found on screening actually are not asymptomatic, because when I talk to people who are over 50, who have obesity, who have diabetes, very few of them are not getting short of breath with exertion or suffering from some degree of fatigue. And we usually think it is just life or deconditioning. A significant proportion of them, on then checking an echo, I'll bet you, will be found to have heart failure. What's the take-home point? This is further support for what is already embedded in the recommendations to check either a BNP or an NT-proBNP on an annual basis. Our next article is from Diabetes Care, titled Risk of Acute Pancreatitis and Biliary Events After Initiation of Incretin-Based Medications in Patients with Type 2 Diabetes. Patients with Type 2 diabetes, we know, are at increased risk of acute pancreatitis as well as biliary events, but the evidence remains mixed regarding the association between incretin-based therapies, that is GLP-1s and DPP-4s, and those outcomes. So the authors here sought to look at that using a Medicare fee-for-service and 2 U.S. commercial claims databases. They identified pairwise cohorts and propensity scored stratification of adults who had type 2 diabetes without prior pancreatitis or biliary disease, who initiated treatment with either a GLP-1 versus an SGLT2, or a DPP-4 versus an SGLT2, or a GLP-1 versus a DPP-4. What they found was that GLP-1s and DPP-4 initiators had similar risk of acute pancreatitis compared with SGLT2 initiators, and that was a hazard ratio of 1.01, so that was essentially the same. However, both GLP-1s and DPP-4s, when initiated and followed, showed a modestly increased risk of biliary disease compared with the SGLT2 initiators, and that was a hazard ratio of 1.15, so a 15% increase and a hazard ratio of 1.22, 22% increase respectively, equivalent to fewer, though, than one event per 1,000 person years. John?
So, Neil, I find this to be always kind of very fascinating. So, kind of this pancreatitis risk. So, the GLP-1s come on the scene, the DPP-4s come on the scene, and kind of this talk of pancreatitis. And if you looked in the package insert, it would talk about caution in someone who ever had pancreatitis, or caution for someone at risk for pancreatitis. Well, who's at risk for pancreatitis? People with diabetes. So if you look at multiple papers over the last 20 years, the hazard ratio roughly for acute pancreatitis in someone who has diabetes versus someone who doesn't have diabetes is about 1.74. So just having diabetes puts you at increased risk for pancreatitis. So the question is, and and this paper really doesn't support this, really comparing the DPP-4s to the SGLT2s, but maybe they all do a little bit, right? And you're comparing it, you're not necessarily, there's not a control group there in this study. So we don't completely know that someone with diabetes who is on none of those drugs, someone who's on insulin or whatever, what would that kind of risk be? So I would feel okay using these medicines in someone at risk for pancreatitis, because I would use these in someone who has diabetes, who has a 75% higher risk than someone without diabetes in these studies. So I would feel good in that risk. The person with a history of pancreatitis kind of depends on what it was, right? Did someone have a necrotizing pancreatitis that was in the ICU and was on a vent and all this other things, or someone who had some abdominal pain and had a lipase that was 15 points above normal and had a pretty normal looking CAT scan. I'm not sure I would make that a contraindication forever. Although in our EMR, it's going to say that person had acute pancreatitis, and it's probably going to pop something up. So I think that that's interesting. The increased case of biliary disease, 1 per 1,000 patient years, doesn't seem like a whole lot, right? So, you have 100 patients who are on these medicines for 10 years. One more of them will have, some biliary disease, which, for the most part, doesn't tend to have horrible end of life kind of consequences and things like that. So I would be reassured. If you look in some of the older articles, though, around pancreatitis, it might say that people with pancreatitis do a little better with insulin. And in this with the biliary disease, maybe it's a pinch better, 15% lower in someone an SGLT2 and someone with some biliary disease. So I think this should be kind of reassuring on both fronts. Our next article is from JAMA Open Network and in diabetes and endocrinology, and looked at continuous glucose monitoring frequency and glycemic control in patients with type 2 diabetes. So this study was to look at the association of CGM frequency with glycemic status over a 12-month period versus no CGM use. So it was a retrospective propensity scored matched cross-sectional study that used Optum-defined market clarity data obtained between January 1st, 2019 and December 31st, 2023, including data from 6 months prior to each participant's index date with 12 months follow-up. They were participants with type 2 diabetes who were over the age of 18 and had a hemoglobin A1C between 7 and 15 at baseline. So they looked at the number of days using the CGM during the 12-month post-index period, and the frequency was 1 to greater to 1 than less than 90 days, frequency 2, greater than 90 to less than 180 days, frequency 3, 180 to 270, frequency 4, greater than 270. And then there was the control group. The primary outcome was change in A1C relative to the frequency of CGM versus no CGM. So the analysis included over 9,200 patients, of which 4,200 were female. The mean age was 55.9 years, and there were 4,600 plus patients in the control group. There were 1,081 in frequency 1, 1,523 in frequency 2, 2,540 in frequency 3, and 2,485 in frequency 4. High CGM use, which would be frequency 4, was associated with greater reduction in A1C, a decrease of 1.52 versus no CGM use that also had a decrease, but 0.63 percentage points. CGM users experienced the greatest reduction in approximately 3 months. So frequency 1 had a decrease of 0.5 percentage points. Frequency 2, decrease in 0.57. Frequency 3, 0.79. And frequency 4, 0.91 compared with control patients. No further glycemic improvement was observed with frequency in 2 and 3 after 6 months. Improvements in patients with frequency 1 and 4 groups were sustained for the duration of the post-index period. The addition of a GLP-1 receptor agonist in the frequency 4 group was associated with an A1C treatment difference of a decrease in 1.13 percentage points versus controls at approximately 12 months. Neil?
John, this is an interesting study in that, not that it's surprising, but I think it is interesting. And basically, what does it tell us? It tells us that using CGM matters. It helps people get better control. And unlike what some of us, I think, sometimes think that if you use it now and then, so you get motivated, understand your diabetes, that's enough. What this says is that continuous using it for much of the year is better than using it now and then. And after that, it's speculation. Why does it help? Well, I think the two reasons are, one, it allows more regular changes of medicine based on regular updating of data. You don't have to wait that 3 months or more for your A1C to see a sufficient change to change a medicine. And two, it creates an internal feedback loop that patients get when they eat wrong. They see the effect very quickly on their blood sugar. If they exercise, they see that blood sugar going down. And we all respond to natural feedback that is close in time to the behavior that caused that feedback to occur. And we've talked about that on other podcasts. So take home point here, CGM, good, worth using, more. Next article from JAMA is titled An AI-Powered Lifestyle Intervention versus Human Coaching in the Diabetes Prevention Program, a randomized clinical trial. Oh boy, I know who I was rooting for in this one. So we know prediabetes is common. We know the diabetes prevention program is one of the great trials of all time, showing lifestyle intervention decreases progression from prediabetes to diabetes, but it is a resource intensive program. So to determine whether referral to an exclusively artificial intelligence, AI, led lifestyle intervention based on the DPP-4 program was non-inferior to referral to a human-led DPP in achieving recommended thresholds for weight loss and A1C reduction, as well as weekly physical activity among adults with prediabetes and overweight or obesity. The authors developed a randomized trial. It was a phase 3 parallel group pragmatic non-inferiority randomized clinical trial conducted from October 1st, 21 to December 16th, 24 at 2 U.S. clinical sites. That was in Baltimore and Reading. It is worth talking a moment about the interventions to which participants were randomized in a 1-to-1 ratio. They either got referral to an AI-powered DPP-4 lifestyle intervention delivered by a mobile app with Bluetooth-enabled digital scale, and they also used some step counters, or referral to a human coach-led lifestyle intervention. It's important to understand that Human Coach was delivered remotely. This was started during part of the COVID pandemic, and the decision was made to deliver the lifestyle interventions in a remote manner. It's worth discussing what the AI-based program looked like because we're not real familiar with that sort of thing. The participants received a digital health kit within 8 to 12 days of signing up. It had a Bluetooth scale that connected with an app. And what was fascinating here is the app delivered personalized push notifications for weight management, physical activity, and nutrition. And it was informed by the data that it collected, meal logging, weight measurements, as well as things like geolocation, which was fascinating, that was tracked through the phone. So for instance, if you were walking into the supermarket, you would get a text saying, let's make some good choices while we're shopping here. And those texts would give you the choices based on what your eating has been so that it was personalized to you. If you hadn't, for instance, exercised on a day where you had planned to, you would get a text saying, might be a good idea to exercise today. And even if you can't do your full exercise program, even if you do part of that program, it's a win. So you have a sense of what they were doing. A total of 368 participants were included. 71% were female. The median BMI was 32. After referral, 93% of the people initiated the AI-led program, and 82% initiated the human-led program. So AI was winning right out of the starting gate. The primary outcome was achieved by 31% in the AI group and 31% in the human group, meeting the criteria for non-inferiority. They were about equal in their outcomes. Oh boy. John?
Neil, not surprising, really. So in March of this year, article in the New England Journal looking at psychotherapy. right? If someone could be referred to Therabot and could get kind of AI-driven psychotherapy, and it showed it did okay. So, but some of the caveats kind of written up in a recent edition of Psychology Today about that. The AI did better with protocol-driven type things. So the undifferentiated, and you and I kind of talk about this, in primary care, is really that seasoned clinician. Really, what differentiates them from a protocol-driven system is someone who can kind of take that undifferentiated patient and kind of unpack it. So the DPP4 coaching, I think, is probably pretty structured, right? If A, then B, if B, then C. And, instead of kind of viewing this as the boogeyman, maybe this becomes kind of a great kind of tool for us, for our patients, which is multitudes, who kind of fall in that, boy, I need to eat a little better, I need to exercise a little bit more, and maybe if I got something to my phone, I would be, because people are doing an awful lot of stupid stuff based on what's coming across their phone. Maybe something coming smart and helpful coming across their phone. Wouldn't that be revolutionary instead of another TikTok or whatever people are wasting? So I find this to be interesting. I don't think I would want this to kind of replace, kind of everything else. But I think instituting a protocol, and we're on a diabetes podcast right now. You could imagine that in the years ahead that insulin dosing recommendations will go through some artificial intelligence. You could imagine that warfarin dosing, and kind of something that kind of loops in with some artificial intelligence to tell people to, adjust their dose. Things, we just talked about congestive heart failure. If someone's weight goes up, you could see a lot of this stuff that is very protocol driven, kind of using this AI technology. So I don't find it surprising. I find it interesting. Came from Diabetes and Obesity and Metabolism, and it looked at two-tier screening approach for liver fibrosis stratification in outpatients with type 2 diabetes, a multicenter cross-sectional study. So this study retrospectively enrolled over 1,200 older Italian outpatients who had type 2 diabetes, who underwent a vibration-controlled transient elastography, which we will refer to as VCTE, with liver stiffness measurement and controlled attenuation parameter. People with metabolic liver disease was defined as having a CAP greater than 248. Significant liver fibrosis was defined as having greater than 8 kPa. Compensated advanced chronic liver disease as liver stiffness measurement greater than 10, and clinically significant portal hypertension, that number being greater than 25 kPa, or LSM greater than 20 and platelet count under 150. And a Fib index was calculated in all participants. The prevalence of having metabolic dysfunction associated liver disease, significant liver fibrosis, chronic advanced chronic liver disease, or chronic systemic portal hypertension were 71.3, 21.1, 11.7, and 1.7 respectively. A two-tiered screening strategy for fibrosis using the FIB-4 index and the VCTE showed that among patients with a normal FIB-4 index, 83.3 had stiffness under 8, and 126 had it greater than 8. Sensitivity, specificity, negative, and positive predictive value of the FIB-4 index for detecting a level greater than 8 was 50.4, 66.3, 83.3, and 28.6 respectively. Increased body weight, adjusted odds ratio of 3.34, and elevated AST levels, adjusted odds ratio 1.54, were the strongest predictors of significant liver fibrosis. Neil?
John, let me put this article into context. So the authors said that this supported the guideline approach, and the guideline approach is that we should be screening everyone with diabetes and obesity with a FIB-4, and if they have a score less than 1.3, they fall out of the need to do any further evaluation. The issue, though, that this study really nicely delineates is that the FIB-4 doesn't have anywhere near a perfect negative predictive value. In fact, that would miss about 17% of people with significant liver fibrosis. And I just want to focus on that particular issue because clinically that's what we're looking for now, people with F2 and F3 fibrosis, because those are the people who are eligible for the FDA-approved treatments for MASH, being resmetirom and semaglutide at this point. There are plenty more in the pipeline. But it means that you be missing about 17% of the people who have MASH that would be eligible for treatment if you did nothing in addition to the FIB-4. And I find that a bit concerning. And you know, the reason for that, in this study, the prevalence of MASLD and MASH was the same as we see in other studies. 71% of the people had MASLD, about 21% had significant liver fibrosis. So what do we do with this information? Because we wouldn't want to jump and do elastography on everybody. So what I take from this, and here I'm using the part that you said last, that people who had particularly increased body weight were at higher risk of fibrosis. Same with high ALT levels. Well, we do the FIB-4, but we don't adhere to it religiously. We then think, and if someone has class 3 obesity or elevated LFTs and they have a FIB-4 less than 1.3, maybe we go on and do that transient elastography as well. The other group I worry about are people who are younger, because remember, the FIB-4 is driven by age. You get a higher number the higher your age is, in a way that's very similar to our ASCVD calculator. And if nothing else changes and you're a decade older, your score goes up. So if someone has a score near that borderline score and they were, say, 30 or 40, I might go ahead and check them anyway. I think this is an important article and will likely influence future guidelines. Our final article of this issue is from BMJ Open Diabetes Research and Care and is titled Change in Urine Albumin-to-Creatinine Ratio and Clinical Outcomes in Patients with Chronic Kidney Disease and Type 2 Diabetes. The study aimed to investigate the association between the change in urine albumin-to-creatinine ratio and clinical outcomes in patients with chronic kidney disease and type 2 diabetes. They looked at adult patients with an elevated UACR greater than 30 in initial testing after the diagnosis of type 2 diabetes and CKD, and it was identified from an Optum electronic health records database. We're hearing about this data set a lot because it is one that encompasses somewhere around 70 million people's information. A UACR change from initial to last test from 6 to 24 months was categorized as either a greater than 30% decrease, stable, or a greater than 30% increase in UACR. And what they found was that compared with patients who had a stable UACR, there were 35,000 of them, those who had greater than a 30% decrease in their UACR, 89,000 people, had a lower risk of all-cause mortality, a 7% lower risk, and a lower risk of composite cardiovascular outcomes as well as CKD progression. And patients who had an increase UACR of greater than 30% had a higher risk of each of those endpoints. John?
So Neil, there are a lot of things methodologically I liked about this study. And starting off that better or worse had to be more than 30%. So, you know, these changes that are just a couple points that would be, say, well, it's better or it's worse. I kind of liked that it really defined better or worse in a nice way. One of the things, though, in this particular study, I think the average time between microalbumins was 18 months. And maybe this is complete real world data, and that's what's going on out there. I think this is just yet another reminder to us as we are going to hear more and more and more and more and more about this kind of cardiorenal link. So if we can make people's kidneys better in the setting of diabetes here, we're probably going to decrease their chance of having cardiovascular disease. Because really, if you look at the difference for that person whose microalbumin is 30% worse, but maybe their creatinine has not changed or their GFR hasn't changed, their chance of ending up on dialysis is the relative change in those numbers might not be huge, or their need for being on a transplant list or whatever might not be huge, but it clearly accelerates the risk of having cardiovascular disease, and that is what kills most people with renal disease. So one of the things this is probably something very easy for electronic records to follow, and I think once upon a time, you and I in primary care, we were judged, did our patient have a microalbumin? But I really didn't see ever really that kind of judgment. Well, what did you do about that microalbumin? Or maybe if it did you start an ACE or did you start an ARB? And that was it. And I think a lot of people might just check it and not do anything about it. I hope not. But if it is elevated, starting off with putting someone on an ACE or an ARB, but pushing the dose of that ACE or ARB to really try to get that 30% reduction. And I think that really should be a little bit of our charge if you have that person with some increased microalbumin, and I start an ACE or an ARB, that I can get that down to 30%. If that doesn't work, that maybe I'm adding on one of the other categories. I'm adding an SGLT2. I'm adding, one of the MRA type medicines to kind of protect people's kidneys. But I think this is going to be more and more the challenge for those of us in primary care, for those people who are in that CKD3, that CKD4, to make those differences so someone never becomes CKD5.
John, before we close, I want to share some important news with our listeners. As you know, in addition to diabetes, we've been covering the full range of cardiometabolic conditions, and so our name is going to be changing to meet that consistent mission. Our podcast will be rebranded as Diabetes, Obesity, and Cardiometabolic Update. I know. You're already thinking, and you're right. The new name is Doc Update, Diabetes, Obesity, and Cardiometabolic Update. You'll notice this when the change is made on your subscriber feed. We'll have a new title and branding, same great information. For more information and links to the articles that we discussed in this issue, just go to diabetesjournal.org. Until next month, keep listening
and keep learning.